Welcome to Pain Institute of Indonesia. My name is Fajar Rizky. On behalf of the organizing committee, we would like to extend our thank you for everyone who has joined in this digital dialogue of Interventional Pain Update Series 4. We would also like to greet everyone who have followed us from episode 1 and thank you for joining us once again. We are honored to have with us today our guest expert live all the way from New York, Prof. Sudhir Diwan MD FIPP DABIPP. Today's webinar is brought to you by Pain Institute of Indonesia and supporting organizer by Eskolab Academy, a B. Brown company. We would like to convey an important message and guideline. Please note that your microphone is muted throughout the session. Please post your question in the Q&A section anytime throughout the session, and this session will be recorded. For today's agenda, after this, there is opening remarks by Pain Institute of Indonesia, and after that, we will start the regenerative medicine of discogenic pain presentation by Prof. Sudhir Diwan MD FIPP DABIPP, and we also provide a question and answer with panel discussion and then closing remarks. Faculty of the day, Prof. Sudhir Diwan MD FIPP DABIPP. Hi, Professor. How are you?
Can you hear me?
Yeah, we can hear you.
Yes. Good morning to everybody.
Good morning, Professor. How are you, Professor?
Good, very good. I'm very honored to be part of this talk. And thank you for inviting me.
Yeah, and without further ado, ladies and gentlemen, please welcome our host and moderator of Yosi Asmara Pain Talk, Yosi Asmara MD FIPP, FIPM, FIPP Tips, and Dr. Yosi, the time is yours.
Okay, thank you, Fajri, for the time. Hello, everyone. Welcome to YAP Talk, Yosi Asmara Pain Talk. I'm so happy that today we gather with a lot of participants. Today we have 946 participants from all around the world, and I'm very happy. This webinar is the fourth episode of webinar. We have 3 successful webinar before. The first one was with Dr. Helen Gareli from Iran and Dr. Said Sofran from Indonesia. And then the second one is we have Andrea Mansana from Brazil. And the third one we have Agnes Stogica from Hungary. And today we have a special guest that very famous, Professor Sudhir Diwan, MD, FIPP DABIPP. He is a president of Advanced Spine on Park Avenue, New York, and immediate past president of ASIP. Hello, Professor.
Hello, how are you, Yosi?
Hi, fine. How are you?
Good. Thank you. Thank you for inviting me for this talk.
Yes, I'm very honored that you can talk here in YAP Talk with me. I'm very happy that you have that you come to the talk with us, and everyone in Indonesia actually very happy that they can hear about your talk. It is a very interesting topic, I think. And before we start, I will read your CV first. Actually, it's a very long CV. Wow, it's very tremendous. Okay, Prof. Sudhir Diwan, nationally and internationally recognized as a key opinion leader in the field of pain management. He's a president of Advanced Spine on Park Avenue, New York, and associate clinical professor at Albert Einstein College of Medicine in New York. Professor Diwan has published extensively in prestigious peer-reviewed medical journals and medical books on a variety of pain management topics. He's an editorial board of the Pain Physician Journal, an official journal of American Society of Pain Physician, and also editorial journal for pain practice. It is an official journal of World Institute of Pain. And he is an examiner for the certification board for American Board of Interventional Pain Physician and Fellow of Interventional Pain Practice, FIPP, by the World Institute of Pain. He's also a co-editor of Intrathecal Drug Delivery for Pain and Spasticity books and D1 Stats Atlas of Pain Medicine Procedure, and also the book of Advanced Procedure of Pain Management, Step by Step. Currently, he is an executive director of NYSIPP and co-chairman of annual NYSEPP Pain Medicine Symposium and immediate past president of ASIP. So, before we begin, Professor, I see here for the participant, there is a Professor Leong Lim from Netherlands.
Oh, very nice.
Yes, he also joined us here. Maybe we can, later in the Q&A, we can talk a little bit with Professor Leong Lim. Okay.
Very nice. Yeah.
So, Professor Sudhir, now the time is yours for the presentation.
Okay, so I can start share the screen.
Yes, Professor.
All right, you can see my screen, correct?
Yes, you can see. This is good.
Excellent. So again, thank you very much, Yosi, to invite me for this talk series. I'm from New York, and it's 9 o'clock here. And I wish you all good morning or good evening, good afternoon, based on your native time. My talk today is the regenerative medicine for discogenic pain. This is a slide of my conflict of interest. Only relevant conflict is I am also a paid faculty and course co-director for Advanced Regenerative Medicine Institute, where I lecture regularly. To understand the effect and the purpose and the goal of the regenerative medicine, I will start with some basics of the disc. The disc is contained by two end plates. These are cartilaginous structure, and then surrounded by the annulus fibrous, because annulus fibrosus. And with that, in the center, there is a gelatinous structure called nucleus pulposus. The other most important thing to understand is the extracellular matrix. Extracellular matrix is the key for the degeneration and regeneration. It is made of the structural proteins and proteoglycans. It provides the cellular support anchorage. It also regulates the migration and adhesions of the cells. It provides the mechanical support. But most important that if your extracellular matrix is healthy and good enough, then it can also provide the regeneration of the cells, of the disc cells. Now, what happens in a degenerative disc disease? It basically, disc dries. You lose the water content of the disc, and the height of the disc gets less shortened. The disc pressure goes down, so basically it becomes a low pressure disc. And the symptomatology is based on the biochemical effect, which is the inflammatory mediators, sensitizing the peripheral nociceptors, and biomechanical, which is the more advanced situation where, because of the this advanced degeneration, there is instability of the spine. And this is how it looks like when it is advanced, where there is no space between the vertebra. The end plates are almost aligned and disc is gone, and that contributes to instability of the spine. These are some grading to understand the grade 1. There is a pretty good homogeneous hyperintense white disc, and then it advances to grade 5, which is inhomogeneous hypointense dark disc. This is normal progression. So the bad thing about the degeneration is once it starts, it continuously progresses. The good thing is that it progresses very, very slow, but it does not get back to where it was. Once it starts, it starts. So a little bit more details of degenerative process. Degeneration is secondary to repeated trauma, some genetic predilection, and also compromised nutrition. So if you have a repeated microtrauma and the nutrition is compromised, that is the start of the degeneration process in the disc. The nutrition, it comes through the end plates by diffusion. So if your end plates are calcified, the nutrition will be compromised. The other problem is there is imbalance between anabolism and catabolism. If catabolism increases, that actually depletes the cells. So you always have to have a better anabolism than catabolism. And when catabolism increases, there is a progressive loss of chondrocytes, extracellular matrix, and then the degeneration continuously progresses. On the left side below slide, you can see there is also a hostile microenvironment where the oxygen tension goes down, the glucose goes down, and the lactic acidosis goes up. This hostile microenvironment is the one that causes the progress of the degeneration, and then eventually you can see on the right side, this is how it looks like when the degeneration keeps continually progressing. I also want to clarify one thing. There are two different processes that you have to understand. The inflammatory process that happens in the disc are in the periphery, whether it's because of the herniated disc and release of the all vasoactive inflammatory components, or because of the radial tears in the annular fibrosis that also sensitizes the nociceptors. But the inflammatory process is a peripheral process, while the degeneration is the central process. It starts in the center and then it progresses towards the periphery. Just to understand, because if you treat the inflammation, you can treat the pain. And that's why all our injections are focused towards the reducing the inflammation. This is a very quick review of slides for the procedures offered for the advanced, for the degenerative disc. You have IDET, you have intradiscal biculoplasty or radiofrequency annuloplasty. All these procedures are for symptomatic relief of the pain from the degenerative annulus. It does not, however, address the root cause, which is the degeneration. It just provides a symptomatic relief. Now, when the degeneration keeps progressing, then it causes the instability and stenosis and other issues of the spine, on the spine. And when it continuously progresses, then you need one surgery after another, because surgery is designed to symptomatic relief. It again does not address the root cause. And when you have a surgery, like this, where you kind of decompress and fuse because of the pain, but then what it does is called the adjacent segment disease, where segment above and segment below is also affected, and after a few years, you expand the surgery. I just want to bring a couple of points here. This is a Cochrane review that came out of 1999, and it says that 10% of the patients of the lumbar spine disorders, they cost us the 80% of the healthcare and social cost. So just the 10% of patients takes away the 80% of the healthcare and social cost. But most important is this: the Cochrane review says that there is no scientific evidence on the effectiveness of any form of surgical decompression or fusion for a degenerative lumbar spondylosis compared to natural history, placebo, and conservative treatment. So it is very clear that whether you do a surgery or you don't do surgery, there is no really much difference on a long run. But I also want to bring to your knowledge this article on failed back surgery syndrome. This is a very interesting article, reviewed all the causes of why there is such a high failed back surgery syndrome. And it says that in spite of the advance in surgical technology and the hardware used for the surgery, the incidence of the failed back surgery has not declined. So in the last 3 decades, if you see, the hardware you were using 30 years ago may be different than now. However, the outcome has not changed. And this article says that the only way you want to prevent the failed back surgery syndrome happening is by preventing the surgery. And so that's really interesting to know. I also want to say a couple of points for the herniation. Disc herniation is a different pathology than disc degeneration. We all know that. It is a normal disc. The intradiscal pressure is very, very high. The herniation happens either there is a high intradiscal pressure and there is a weak or ruptured annulus. If they have 2 procedures like this, then the herniation happens. The symptomatology initially is because of the chemical irritation of the nerves, because of the inflammatory soup relieved by the disc. And then as the herniation increases, the symptomatology also changes from pain to loss of function, which is because of the physical effect of the herniated disc on the nerve. These are the list of procedures that are designed to reduce the pressure and reduce the pressure on the nerve. Again, this does not really address to the cause effect, but cause of this problem, but symptomatic relief of the herniated disc. We are actually, this is I think the microdiscectomy or endoscopic discectomy is really very cutting edge technology that we are using to remove the disc, and patient does not really need to be hospitalized. In here, I do endoscopic discectomy. Sometimes I do under general anesthesia, but patient goes home and they after half an hour to 1 hour from the recovery room. The issue with this procedure is also it does not address the root cause of herniation. You remove the part of the herniation that was causing the symptoms. So yes, it does provide the symptomatic relief, and sometimes it prevents the neurological deficit, but it does not prevent the reherniation because your root cause annular defect has not been addressed. This is the article talks about that if you look at the radiographic recurrence rate, it is as high as 1 in 4 patients, and quite a few patients are symptomatic. The annular closure has been attempted, has not been successful yet. There are collagen gels has been applied. Sometimes some techniques are shown some promising, but most techniques have not really shown. I think the collagen gel has been quite effective in that. So with that background in mind, let's review our protocol. This is our pain protocol. Patients comes with a discogenic pain. You start with epidurals, and if there is a facets, you do these blocks. And then either you jump to minimally invasive procedures and then neuromodulation, or you start neuromodulation and then you do, these are interchangeable treatment options. The surgical options is all over. Whenever patient goes to see the surgery, surgeon, of course, they are surgeons and they will consider the surgery whenever patient goes to see them. But now we have regenerative medicine option to offer our patients. And I personally believe that for all interventional pain physicians, our future will be more and more minimally invasive procedure. We are not just injection experts, but we are interventional spine experts. So we will be doing more and more minimally invasive procedure. We will also be doing more neuromodulators because the research going on neurostimulators is unbelievable. So our neurostimulator will be a very big part of our practice. And the third component is going to be part of our practice as interventional pain physicians is regenerative medicine. The ASIP has published guidelines, and this is came out last year. Studies are still being done, and if you Google, there is plenty of evidence. But according to this review, there is a level 3 evidence for the intradiscal injections of PRP and stem cells. Now, question is why we should use the regenerative medicine. First, our goal is to really reduce the pain and inflammation. And studies have shown that pain and inflammation is relieved by injecting either the PRP or stem cells. We also have an intention to heal the degenerated disc and annular defect. If we can heal this, then we are addressing the root cause. We want to stop or slow the progress of degeneration. We want to provide the regeneration of the tissue. And the most important is this is the only treatment option that you offer to your patient. It has potential to change the course of the disease. And this is key because it addresses the root cause. All this surgical decompression, microdiscectomy, or other intradiscal procedures, none of them addresses the root cause, and none of has any influence on changing the course of the disease. This is the only treatment option that can change the course of the disease. The biologic treatment options that we have is gene therapy. I'm not going to talk too much about gene therapy today because of limited time, but I will be discussing the cellular therapy and acellular therapy. Acellular therapy is where there are no actually cells, but different types of proteins that we are using. And this is exosomes and microvesicles are very, very important. Exosomes I have not used for the disc, but I have used for other areas, and it's very effective. Alpha-2 macroglobulin. This is a very key macroglobulin protein product which actually protects the cartilage, and this is going to be a very big time in our regenerative medicine to use alpha-2 macroglobulin. High-density collagen has been studied to defect the annular defect. We can also use the recombinant proteins, and intradiscal fibrin sealant was actually invented for this purpose, really didn't work that well. Cellular therapy we have is you have a PRP, platelet-rich plasma. It is also called protein-rich plasma, depending what kind of a PRP product you are using. I have a slide down the road. I will show you what is the difference. The autologous stem cells coming from your own bone marrow or own adipose tissue. Adipose tissue stem cells are not allowed to use unless you are part of the research project, because it's a control product, so you cannot do it because it requires the manipulation of the tissue and tissue digestion, so that you cannot use it, but bone marrow is allowed to use. Allogenic stem cells are commercially available, either from the embryonic stem cells or expanded cells are available. And there are some people use platelet-rich plasma plus stem cells. I used to be a big believer that we should use PRP plus stem cells, but I think the stem cells have all the components of PRP. So now more and more people are using just the stem cells, and they do not mix it with the PRP unless the cells are allogenic stem cells. If the stem cells are allogenic, then I think it makes sense to use the PRP. So the treatment goals for the degenerative disc, you want to improve the ratio of cell production and cell loss. You want to have more cell production and less cell loss. You want to improve the microenvironment where you have improve the oxygenation of this cell and decrease the lactic acidosis. Provide the anabolic state and reduce the catabolic state. Catabolic state is where all the cytokines are produced, and cytokines are very inflammatory and contributes to chronic pain. So you have to improve the state. You also want to improve the stimulation of the proteoglycan, because proteoglycans are the one that keeps the disc hydrated. If these are depleted, then your disc will become degenerated. But also most important is to make sure that you promote the formation of extracellular matrix, because extracellular matrix not only provides the scaffolding, but also provides the nutrition to the disc cells and a regeneration process. So you want to halt the progress of degeneration and provide the regeneration of the disc cell, and that's the goal of using the regenerative medicine for intradiscal or discogenic pain. The options you have are you can use a viral vector and encoding protein. You can inject into the disc, or you can harvest the cells. These cells are harvested either mostly from the disc removed from the herniation. That part of the disc is taken to the lab, and they either make a genetic modification and transformed cells are transplanted, or they expand the cell line, cultivate the cells in the lab, and then transplant the cells in the disc. Or these cells are again in the lab are they are taken to the lab, and the scaffold is produced, and that scaffold is then seeded into the disc to provide the support to the cells. You can also have autologous mesenchymal cells. These are actually all parasites or progenitors that you inject directly to the disc, or you can differentiate into differentiated cells and inject the differentiated cell. The most common practice is you take the bone marrow, you concentrate, and then progenitor and cells or parasites are injected into the disc directly. Gene therapy, as I said, I'm not going to spend too much time, but this is a review article, and it shows there is really a lot of encouraging results. It can help you to improve the balance between the synthesis of the cells and catabolism, and the gene therapy is going to be very, very effective down the road. Only problem is that because they have to use the viral vector, and viral vector actually sometimes the risk of infection and malignancy. So latest gene therapy actually are now working on using the non-viral vector, and that might be very interesting to see what they bring in. So as I was talking about earlier, that A2M, the alpha-2 macroglobulin is a very good product for the disc, because end plates are cartilage. Whenever cartilage is calcified, the nutrition is compromised. So if we can prevent the health of the cartilage, then it will be really good for the health of the disc. This study actually talks about where they have this skin, the disc marker is called fibronectin aggregate complex. It's a marker. Those patients who were positive for this marker were injected alpha-2 macroglobulin. And the 24 patients looked at the ODI VS at 3 months and 6 months, and they found that the A2M may be an effective biologic treatment in discogenic pain. The degenerated discs are more likely to demonstrate clinical improvement with A2M. Again, A2M is a broad spectrum protease inhibitor, and as you know, proteases are they destroy the cartilage. So A2M is good for the health of the cartilage. Now the key is where you get the A2M from. Actually, autologous A2M is available. When you have this PRP, you have 3 levels. You have red cells in the bottom, and then you have a buffy coat, and you have a top level, which is a LOH, the plasma level. This is called PPP, platelet poor plasma. And platelet poor plasma has all the proteins that you're talking about, which are fibronectin, fibrinogen, vitronectin. These are good for the scaffolding. There is also anti-inflammatory proteins, IREP are also in there. and most important, there is the A2M. So um, this platelet poor plasma is taken in a different syringe, and then there is a concentrating kit is available, and you can concentrate, because in this platelet poor plasma, 90% is water and 10% is all the protein. So if as much as water you can take out, then concentrated part is all nothing but the protein and A2M. Here you can see there is a filter here. When you push the solution from through the filter, the solution comes in this series and water comes this series. So this is a concentrating kit. PRP we use only because it provides us all the growth factors. There are multiple growth factors. This is just a small list of growth factors. But that is the use of PRP, is because it provides all important growth factors. Platelet activation, there is a kind of debate. I personally never activate the PRP solution, because the process of injecting releases the tissue thrombin, and that automatically activates the PRP, so you don't really need to do. But there is a process to activate outside. If you activate outside, then you have to inject the PRP within a couple of minutes, because otherwise it will become very thick solution. So there is no need to do that. There are a couple of issues I want to discuss about PRP. One is that there is so many issues about the standardization, because there are so many kits available. This is called a gravitational system. There are multiple systems available where your cells will settle in the down, and at the bottom, the middle part will be the platelets, and then top part will be all the plasma. It is a platelet-rich plasma, so any solution gives you a high amount of protein, and protein also gives you a high amount of white cells. And this, if you take just the this part, then PPP has to be concentrated to get the A2M. The other system is a closed system. This is actually very good, where it's a program. You put the blood and you put your amount of PRP required, and it gives you a final product. The problem is the final product is so red that it gives you more red cells. There is no Buffycoat, and it's more leukocytes and more RBCs. This is the kit I use called ACP, autologous concentrated plasma. It's a 2 syringe, where what you do is you don't have a Buffycoat, but you have lower platelet concentration, but also you have a lower platelets, and you have no RBCs, and the platelets is mixed with the A2M. So I always like this, and I've changed my practice for last 2 years, and I really have a fantastic results. Issue with the intradiscal PRP, the cytokine always affects us. The growth factors have a very short half-life. The intradiscal environment is avascular, hypoxic environment, and we don't know how long these proteins can survive. And we also don't know the matrix that we synthesize is close to the native matrix or not. There are also issues of PRP with or without RBCs, PRP with or without WBCs. This one study talks about what is good product, and what they found out in this study is that leukocyte-rich PRP and RBCs resulted into significant death of synoviocytes. So we all would like to have PRP with no RBCs and very, very few leukocytes. Also, a little bit of a discography. Discography is important before you inject, because it tells you the morphology and annular tear. Also, most important is the disc pressure. So it helps you when you inject. It's a high pressure or low pressure. Especially in a low pressure disc, you don't want to inject with high pressure, because your solution will be diffused out. If the disc is a high pressure, that's very important to know, because in a high pressure disc, your intradiscal volume will be very, very low, because even a little bit of volume will increase the high pressure, and you will aggravate the symptoms. So it is very, very important to know discography. I always do it before I do my regenerative medicine. These are the indications that I use. All kinds of degenerative disease at any stage, with or without radiculopathy, herniated disc, with or without radicular pain. If those patients who required the surgery, either because of the neurological deficit or fragmented disc, you can do at the time of the surgery or after the surgery, you can still use the regenerative medicine to provide the healing to that particular disc. Um, so these are some of the cases that I have done for the degenerative disc. Now you can see this patient, the degenerative disc is very advanced. You can just see a little line of the contrast. There is not much really disc left. So it's a very narrow disc. The opening pressure is very, very low. There is a radial tear. So what it means is when you inject with the high pressure, your solution will be diffused out. Um, and then it will go in the epidural space. It's not a problem to have an epidural space, but you are injecting then less volume than where it should go and more volume that you are not intending to inject. So pressure while injection is very important for degenerative disc. Peridiscal injection, there is no reports in the literature about a peridiscal injection procedure, but I have used it every now and then. The injection in cervical disc is totally different. One thing is, a lot of people are scared to do the cervical disc. I have been doing for a while, so I'm very comfortable. The volume requirement is very, very low. Discs are very low pressure disc, so volume is required is very, very low. There is no weight bearing issues. So degenerative process is also later as compared to the lumbar disc. The volume is 0.5 to 0.75 ml per disc as compared to 1.5 to 2 ml for lumbar or lower thoracic disc. Usually I like to enter the right side because of the other structure on the left side comes in your way. If you could not do the left side, right side of disc entry, and if you have to go to left side, then make sure you use ultrasound to protect other structures. So this is the peridiscal injection that I did, and this patient was 90-year-old. You can see L5S1. This is already autofusion. I thought there might be some disc. I thought on MRI, but I could not get into. So I had the solution. I injected peridiscally, and this patient actually did very well at 1.5 year last follow-up. She still had a pretty good pain control. I have lost follow-up on her later on, maybe COVID, maybe health issue, but I have not seen her patient for a while. Now, goal for herniated disc, you want to treat the inflammation, you want to decompress the nerve, and you also want to make sure that the lifestyle is changed to minimize the discal, intradiscal pressure, no bending forward and lifting the weight and things like this. But again, we really have to focus on how to heal the annular tear so that the reherniation can be prevented. This is a study that came out 5 years ago. This guy, Kevin Poza, he devised this, this injector called Biostat delivery system. And he injected fibrin sealant into 15 patients to seal the tears. The problem with this original series was there were 9 patients had adverse reaction, and out of 9 patients, 1 patient actually had a discitis. And that kind of scared me because you don't want discitis within just a small group of 15 patients. However, that study shows that the fibrin sealant may be effective into sealing the tears. There is a lot of basic science studies going on. This study is going on at Cornell right now, where the annulus fibrous cells were mixed with the high density collagen, and they compared the high annular fibrous cells, the collagen alone, and then annular fibrous cells with collagen. And they found out that the healing process was much better when they used the annulus fibrous cells and the high density collagen. You can see here in the top left, top right, the defect is almost sealed. So it is very effective. Still basic science. It has been not tried in the patients yet. This one device I want to talk about, this is also has been, it's a knee arthroscope or tissue scope. It is a 14 gauge arthroscope used for the diagnostic purpose. It is FDA approved. But the key is that it's only 14 gauge needle and it has 9 inch LCD monitor that gives you an excellent picture. This can provide you call a direct visualization and cell delivery where it should go. Meaning that the PRP, if you want to have a best result, it should be injected where the injury is, because PRP don't migrate. So the direct injury, direct visualized injury at the site of the injury is the way to do the injection down the road. The study is being going on right now for the spine, and we have not used for the spine yet. Regenerative medicine for herniated disc. It's you have to decide where the tear is. Enter the disc on the ipsilateral side of the radicular symptoms, so you know that side is the tear. When you inject, you have to keep the pressure constant, because especially in the intradiscal, you don't use high pressure injection, because that will aggravate the symptoms. And you will not be, if disc is healthy and high pressure, you may not be able to inject anything into the disc. You just keep injecting and bring it your needle out. The issues with this, again, the cytokine will affect the healing process. Intraannular injection is very difficult to perform. Limited volume is required, but the problem is it may not be enough for the healing process. And when you inject into the tear, the part of the volume solution is either diffuse extradiscal or intradiscal. So actual tear may not get enough solution. And just keep in mind, more likely than not, you will aggravate the symptoms, because you are putting some extra solution into the disc that is already high pressure. And so the symptoms will be aggravated for a short time. And it is very important to discuss with the patient, so patient doesn't feel that something wrong has happened. These are some of my patients that I have done the stem cells. Ipsilateral injury, inject intradiscally, so needle goes into the disc. You try to inject, but if there is resistance, high pressure, do not inject. You keep withdrawing the needle until you are into the the annulus fibers, and then inject into the tear, and also inject small volume peridiscally. I think wherever there is a tear, injecting some solution peridiscally makes a lot of sense. The real case scenario is not just you have the herniated disc, or not just that you have a degeneration, is mostly combined. So you have to make your injection modified according to the morphology of that particular patient. This is initial study presented in the orthopedic conference in 2012 with 6 patients with a very positive results. And after that, there are a lot of studies done. This first study was done in hospital for special surgery on 47 patients. And then they had another follow-up at 2 years, and patients still continued doing very, very well. After that, there are a lot of studies have been done. Pardon me. A lot of studies have been done, and this review article talks about that it is safe, it is effective, and it has really go through this. A couple of slides on the modic changes. This study done in a radiology journal, published in Radiology Journal, does not say that modic changes were changed. However, it was in this abstract published from Brazil showed that after 1 year, the modic changes were changed. So there might be if positive effect of PRP or stem cell on modic changes also. The modic changes, the clinical significance is the modic 1 and modic 2 causes the vertebrogenic pain, and the treatment is surgery. Now we do call Intracept, which is the radio frequency of the VBN nerve is done, but I think there are chances that we might be using for modic changes also. I'm running out of time, but I will quickly go over the mesenchymal stem cells. The mesenchymal stem cells are the one that has a capacity of the differentiation that can differentiate into different cells, but also they have a paracrine property. They secrete the microvesicles and the exosomes, and these are the immunomodulators, anti-inflammatory. It provides the recruitment of the cells and also provides the proliferation. The nomenclature of the stem cells has changed. In 2006, this physician Arnold Kaplan used to call it mesenchymal stem cells. Now he calls it medicinal signaling cells, because what it actually happens is when you inject the mesenchymal stem cells, it stimulates the site-specific stem cells. So this is why he doesn't want to call mesenchymal stem cells. He wants to call it pericytes. And these are the pericytes tightly packed to the blood vessels in subcortical region in the bone marrow. And these pericytes, when injected, it stimulates the mesenchymal cells, and those are activated, and that effect is site-specific and tissue-specific, and that's why the end effect is mesenchymal cells, but the effect is stimulated by cells called pericytes. The key is that you have to have a proper way of aspirating bone marrow, because you have to have a cortical bone marrow aspirated. You have to have a very strong negative pressure so that you get all the subcortical pericytes, because pericytes are tightly bound to the vessel, so you have to use some force to bring them out. And if you do that, also use the smaller syringes and use the smaller volume, use multiple sites to get the best bone marrow. So providing the proper technique of bone marrow aspiration is key to have a good bone marrow. ASIP had done a review and come up with the position statements that bone marrow is a homologous bone marrow is minimally manipulated and is effective in providing the symptomatic treatment. What happens in the bone marrow, you have a hematopoietic cells, you have mesenchymal cells, and you have higher concentration of mesenchymal cells. The best place to take the bone marrow in the body is from posterior superior iliac spine. This is a study came out a long time ago, almost a decade ago, 10 patients for chronic back pain, degenerative disc disease, and they had at 3 months 85% relief, and 1 year was 71% relief. This is another study of the same time, 2-year follow-up. This is also a very positive study where out of 26 patients, 24 patients avoided surgery in 1 year, and 21 patients avoided surgery at the end of 2 years. So this has been very, very effective procedure. The same group looked at the colony CFU, colony forming units. These are the number of progenitors that is viable and capable of proliferation and multiplication, and those numbers are very, very important. And this study shows that in 26 patients older than 40 and CFUs less than 2,000 had the improvement. ODI improvement was 33%, and VAS improved by 30%. Compared to patients who were younger, less than 40, and had a CFUs more than 2,000, had a 70% of improvement the ODI, and also 70% improvement in the VAS score. So the ideal number is around 27, 2,700, and that CFU number is good for the cells. This is a mesoblast cells. This is a study done on the mesenchymal precursor cells, or called also progenitors, and they used into the degenerative disc. At 12-month follow-up, there was 70% of patients treated with MSCs had a 50% reduction in pain at 12 months. So this is also a very positive study. And here in the right lower, you can see those two columns. One is the 6 million cells, and the other one is the next to it is the 18 million of the cells at 2 years and 4. This is 12 months, and this is 2 years follow-up. And you can see the lower cells had a better results than the 24. So, not necessarily larger number have more better results. There are a lot of review. This is also a review article. These are multipotent cells, very effective and can revolutionize the treatment for discogenic lower back pain, and has been very effective in providing the cellular support and regeneration. It has a self-renewal capacity, so that multiply by itself, but it also has immunomodulatory and anti-inflammatory effect. There is another comprehensive review article came out just last year, and also supports that it is a multipotent mesenchymal cells has proposed uniquely to treat the discogenic pain. It reduces the nociceptive disc pain, it slows and reverses the catabolic environment, and it also restores the disc tissue. So this is another review with a very positive disc. The studies are now focusing disc progenitor cells, and progenitor cells are there. So you take the part of the disc that is removed from the disc herniation, take it to lab, and you just expand those cells, and that can also provide you another cell source. This is an animal study to see whether the PRP and stem cells have a better result than one product alone. And in this rabbit, the healing process was better when PRP and stem cells were used together. But this is an animal study, has not been a kind of fully translated to clinical study. This was done 5 years ago. But this is the only study I found that shows that PRP and stem cells is better than one alone. So future of regenerative medicine, the cell source will change. There will be studies of epigenetics. There is studies on progenitor cells to give it a new cell source. The embryonic stem cells versus the induced pluripotent cells. This is a very important topic going to be, because your own cells, somatic cells, are transferred into and induced into pluripotent cells. So there is no any ethical issues going on. Nanotechnology is going to be very effective. It's based on the nanoparticle that will help us into molecular imaging and targeted cell delivery, and that will really help us to do the ECM patterning. And if your extracellular matrix is close to your normal native extracellular matrix, you can reverse the catabolism and anabolism ratio to better anabolism to catabolism. For the ECM patterning, you need the printing, and there is another area is called bioprinting using the bioink, and that will also help us to do a better results. So there is a lot of things going on in tissue engineering, about the exosomes and the microRNA and things like this, and more and more you will see the treatment will be improving. So take home message, this is my last slide. Sorry I took a little more time than I should have. What to inject is very important. You can inject PRP, you can inject A2M, but I like to use PRP plus A2M. This gives you a better result. Autologous stem cells are always better, because autologous stem cells are patient specific. These are their own cells versus allogenic. These are not patient specific. So you can have a bone marrow aspiration, and you can have SVF. SVF is stromal vascular fraction, is derived from the digestion of the adipose tissue. It is not allowed in a clinical practice unless your patient is part of the study. This is limited. Exosomes I have not used in the disc, but I have used for muscles and joints, and very good results. High density collagen is going to be coming pretty soon, and that will help us for the repair of the defect. Where to inject? Intradiscal, intraannular, peridiscal. Subchondral is to injection before the end plate into the vertebra, where they can actually may have potential to improve the health of the end plate cartilage. How to inject? Fluoroscopic guidance is very important. Ultrasound guidance is very important. It doesn't help too much for the disc injection, but it's very important. Targeted cell delivery will be a key down the road, using that 14-to gauge of a needle, and you inject under direct vision. And injection of the precise volume under controlled pressure is going to be a key, because you don't want to aggravate the symptoms also you want to inject just enough volume. Specific indications that this disease intradiscal, annular, tear, intraannular, and if you have mordic changes, we don't have much really knowledge about mordic changes, but so far only way you can do is inject into intradiscal and hoping that it will improve the mordic changes. So with this, I end my presentation here. I thank you all for listening to me. I took a little extra time and I will now take your questions.
Okay, thank you, Professor, for the presentation, for the good presentation. I see here there's a lot of question here, and I'm also have a question for you. So
Sure,
I will
sure.
read it first. Okay, there's a question from Naima Siddiq. When you approach for epidural or caudal steroid
Okay.
or prolo injection procedure, in PRID case, those are refractory to conservative using pharmacotherapy. So
When you approach for epidural,
or caudal or prolo.
okay. Um, this is a PLID is a prolotherapy. So I'm not quite understanding this question. When you approach the epidural corticosteroid injection procedures,
Yeah.
those are, yeah. So I mean, here we don't do really prolotherapy. We do, if anybody has any kind of inflammatory process going on, we inject the steroids right away, either epidurally or transformally. So we don't do prolotherapy. We are a little more aggressive into injecting the transforminols because that has a better results than the epidural. Caudal epidural, I do only if patient had surgery before, and there are a lot of scar tissue that might interfere your spread of the medication, or if patient has a spinal stenosis and you don't have enough room for your needle to go, then I do caudal epidural.
Oh, okay. See, this is my question from Dr. Said.
Okay.
Can you show the Dr. Said face? Firman, I'll try to show Dr. Said. If not, then we change to another question first. Where do you inject the PRP on lumbar spine? Is it only on the disc or any other
So
area on the spine, Professor?
this talk was specifically for discogenic pain, so I have not included other areas. However, you can inject into the facets, you can inject into the ligaments, you can inject into sacroiliac and sacrococcygeal. So I have injected all these areas. Sacroiliac injection also works very, very well. I personally have changed my practice from PRP to autologous stem cells, bone marrow, because PRP you have to repeat every now and then. Autologous stem cells, once you inject it, the results are better and long lasting. But also the autologous stem cells are more expensive than PRP.
How many times that you have to inject if you use the PRP, Professor?
So I'm very, very conservative. I don't inject repeat the PRP unless I have to. The earliest I have repeated PRP in spine is 6 months, and the latest I have repeated is 1 year. So PRP does give you a pretty good lasting pain relief. What really important to find out, which I don't have information yet, is to really do MRI studies after 2-3 years and see whether there is any kind of improvement in the height of the disc. But there is a definite improvement clinically, symptomatically.
Okay, okay, Dr. Said, already, Firman, Dr. Said already. Hello, Dr. Said. Not yet. Okay, Professor,
Yes.
I want to ask you, for PRP injection, is it better we use activated PRP or not? Or
So
non-activated?
you're talking about activated?
Yes, or
Yeah.
non-activated
Yeah.
PRP.
So activated PRP is not necessary for us for the injections, because your your process of injection will release the tissue thrombin, and tissue thrombin will activate PRP itself. So there is no need to activate before injection. However, the surgical colleagues are actually activating the PRP. When you activate PRP, in 2 minutes it becomes a gel-like structure, so you cannot inject it, but you can take a brush and you can paste it over the surgical area to provide the better healing. So that has been practiced, but I personally don't recommend, and I don't activate PRP before the injection.
Okay, Professor. Now, Dr. Syed, we can see Dr. Syed here. Dr.
Yeah.
Syed, you have question for the professor?
Yeah, Professor Sudhir Diwan,
Yeah.
I have one question for you.
Hi, Dr. Syed.
Yeah, hello.
Yeah.
I have one question. Does this regenerative therapy, for example, PRP or stem cell, need
Yeah.
some specific milieu condition around the internal disc or internal disc to work optimally, so that the regenerative therapy, it can work optimally? Can we induce it in practical in practice daily? Yeah.
So in clinical practice, I personally now have been more aggressive. If anybody has degenerative disc, I inject it, whether or not that disc is symptomatic. I still do provocative discogram, and I try to see whether that disc is causing pain. But what your goal is very important. Your goal is to treat the discogenic pain, or your goal is to prevent the degeneration. So what I think is our goal should be to prevent or slow down the degeneration. So you can actually inject anytime when you see degeneration. The key is your conversation with your patient. Patient has to understand what is your purpose of injecting PRP and or stem cells. And you have to explain them that you are trying to prevent the progress of the degeneration, that it doesn't end up into keeps progressing, and then you have spondylolisthesis and you have spinal instability. And that is the purpose you have, is to prevent or slow down the degeneration. That is different than treating the discogenic pain, where you have to really define the source of pain, meaning that does patient have a radial tears where the pain might be coming from. Then you can inject a PRP and have that the tears heal. So, and the same thing is for herniated disc. If there is no neurological deficit, I would inject that disc. But key is you don't inject a lot of solution into the disc, but you inject the solution into the annulus fibrosus, because the tear is annular tear, and that's what your goal is to heal that defect. So if you are injecting for herniated disc, you inject more volume into the annular tear. If you are injecting for degenerative disc, then you inject more volume into the disc depending on to the opening intradiscal pressure.
Okay, Dr. Syed, any other question?
The other question, Professor. How can we assess that we inject the adequate volume of the PRP or stem cell to the patient?
That is a very good question. I would not inject more than 2.5 ml, because then you are really either you will cause a tear or your volume will leak out in the epidural space. So the standard volume that I use is 1.5 to 2 or 2.5 depending on the size of the disc. Again, if there is a tear, if you see a tear, a leak of the contrast in your discogram, that is a very good information, because that will help you how to inject under what pressure. So if that disc with the tear, if you put the needle and if you inject with a high pressure, or all your volume is going to go into the outside the disc, and there is nothing. So you have to inject very slowly, and you have to also control the volume so it doesn't leak out. But normally 2 ml is the adequate volume for the disc injection. For cervical disc is 0.5 to 0.75 ml.
Okay,
Last question.
we have Professor Liang Lim here. Hello, Professor.
Thank you.
You have to unmute first, Professor.
Yes.
Okay.
Okay.
Okay. Okay. Dr. Said, is there any question again for Professor Sudhir?
Last question, yeah.
Okay.
When we use fluoroscopy as a guide of this procedure, is there any effect of radiation to the cell, like a PRP or stem cell or anything else? Thank you.
Oh, okay.
Very, very good questions, and I don't know. I do use fluoroscope. I think it's a good question for me to do some homework. I don't think there is anything in the literature that 1 or 2 fluoroscopic will affect the life of the stem cells, but it's a very good point. It should not affect the platelets because these are all bunch of proteins, but it can affect the progenitor cells in the autologous, the bone marrow. And I will do some homework. I never really thought about that. It's a good point.
Yeah.
Thank you very much.
Thank you, Dr. Said.
Yeah, welcome.
Okay, there's a question, Professor, from Dr. Priambodo. Yeah, he's my mentor. Dear Prof. Diwan, if the patient has severe discogenic pain, what do you do for the symptomatic therapy? Only yes.
So actually, the PRP or stem cells are also for symptomatic treatment. PRP and stem cells are anti-inflammatory, and it helps to reduce the pain also. So even for severe discogenic pain, now, if severe discogenic pain is because of the severe disc herniation with radiation, then it might require surgical intervention. But otherwise, the severe discogenic degeneration, you can do the PRP stem cells. I have not done any kind of radio frequency procedure for annulus fibrosis for a very long time. So I think you can go ahead and do PRP, and your patient will respond well.
And do you do another thing, not only regenerative therapy for the disc, but do you do at the same time ablation therapy, like ramic communicant ablation or something like that, or only injecting the disc with PRP?
So for the disc, I have stopped doing any kind of radio frequency ablation procedure. But
Okay.
for the facets and for sacroiliac joint, I still do it. But if patient is willing to pay, because this is more cash payment, there is no insurance coverage. So if patient is willing to pay, I would prefer to inject PRP or bone marrow because then you have a more definitive, more long-lasting solution. The radio frequency ablation, it's a short acting. After 6 months, your nerves grow back and pain comes back. So you have to do repeatedly. So my choice would be PRP or stem cells.
Okay. Okay, Professor. Actually, me myself, I never do the intradiscal injection for regenerative therapy. Usually, I do only regenerative therapy for the ligament and the joint of the spine, but never for the disc. This is new for me, but it's very good that you give a new side for me about the intradiscal regenerative therapy.
It is actually very important because I'm doing for last 5 years, and everybody knows how to put the needle in the disc because you all know the discogram.
Yes, yes,
so it's really not a difficult procedure to learn.
yes.
What you have to learn is what to inject. I don't really do PRP per se because the platelet-rich plasma, when you take the Buffy cord, you are missing out all the important proteins. So I have changed my kit to ACP, which is autologous concentrated plasma, which gives you all the proteins. There is a somewhat less platelets, but you have less white count, you have no blood cells, and you have more protein, and including the A2M, which is very good for cartilage.
Oh yeah. This is interesting, Professor, about alpha-2 microglobulin, A2M.
Yeah.
Is it more in the PPP, right? Not
Yes.
in the PRP.
Yes. When you have a PRP, then if you take only PRP, you are losing the A2M. So either use the either you don't use the Buffy-coat, or if you have a Buffy-coat, then you take that PPP and you concentrate and then mix it with PRP. But then it becomes very, very expensive. It becomes like as expensive as bone marrow. So what I do is I just do the ACP, which has less platelets, but I have more proteins also. So this is why PRP is also a platelet-rich plasma, but also called protein-rich plasma. So what I use is actually protein-rich plasma.
Oh, that's good, because usually I only use the platelet-rich plasma, and for PPP we don't use it. But now that you say that there's more A2M in the PPP, it will be good. But we have to use it new kit, something like that for the A2M to produce.
So it depends on what kit you are using. If you are using the Buffy-coat for PRP, then you have to concentrate that plasma. But if you use ACP double syringe kit, then you don't have to concentrate. It just gives you directly protein-rich plasma with platelets and protein.
Professor Liang Lim, is there any question from you? Oh.
Hi, Professor Diwan. How are you?
Hi, how are you, Dr. Lam?
Hi.
Very nice to see you.
Nice to see you too. Greetings from the Netherlands.
Yes, very nice to see you.
What are the clinical complications of this regenerative medicine for this disease?
So one of the things that has come unanimously in almost all the literature is the safety. There is a safety and it is very, very effective. Only thing you have to be very careful about is when you use the allogenic cells. I am personally not very keen using any commercially available cells to inject into the disc. I may be down the road, but I'm not there yet. And the difference is the autologous cells are patient specific and safe. The allogenic cells are not patient specific, and safety is about whether it's going to cause some kind of malignancy or not. That ethical issue is still there. So I'm not very a big proponent of allogenic cells for the disc. However, I have done a lot of allogenic cells for hips and shoulders and other joints, but not for the disc. The exosomes are also very effective for other areas, but exosome also has the same, because of the DNA, has the same risk of infection. And I'm not injecting into the disc. I inject somewhere, other areas, but not into the disc. So for my disc, my limitation is PRP autologous and PRP autologous plus stem cells. And that's what I would recommend to everybody, because it's a safe, it's your own cells and no risk and very effective.
Okay, thank you.
Okay.
Thank you, Dr. Liang.
We have another question.
I have one more question. Can I?
Sure.
Okay, Professor.
Yeah. Are you not afraid of causing micro trauma to the annulus when you're injecting into the disc? This is a debate between all the neurosurgeons and the orthopedic surgeons in our country to prevent multiple injections into the disc. What is your opinion regarding to this?
So this is a very good question that takes us back to our debates about the discogram. That when you do discogram, you actually causing more degeneration by putting the needle. There is a slight potential for that. I use 22 gauge needle, and I really don't have kind of histological evaluation of my patients, but symptomatically I don't think my patients have worsened the degeneration, because see, you are promoting anabolic environment, and you're trying to treat the catabolism and improve the anabolism. So even if you have that causing through the needle trauma of the annulus, it may be very negligible, but I don't have any kind of scientific evidence to prove that there is no degeneration. But all the patient, almost every patient that I have treated, they have improved symptomatically.
Okay, thank you.
Thank you,
Okay,
sir.
thank you,
Thank you.
Professor Lim. Okay, we have a question from Dr. Ninandini. I think she already here for the visual. Dr. Ninandini, please. Okay. Hi, doctor.
Hello.
You can ask directly to Professor Sudhir.
Okay. Thank you, Professor Sudhir, for a wonderful presentation.
Thank you. Thank you.
I'm from Nepal, and we have very much limitation with the advanced techniques that we have. So I wanted to ask you about the use of PRP in discogenic pain. What do you think about using PRP for disc and simultaneously doing facet RF or combining it with other procedures?
Very good question. There is nothing really in the literature where both the procedures are combined. I personally have not done it, but there is no use of doing the radio frequency if you are doing the PRP, because PRP has anti-inflammatory components already there, and that is going to heal your disc to begin with. What are we achieving more? I'm not 100% sure, because radio frequency ablation will provide some symptomatic relief, but you are already providing this with the PRP. Now, just that the countries with the limited resources, you really don't have to go for very high expensive kits to get your PRP. You can work with your labs, and they can use a simple mechanism by gravitational way to separate your blood, RBCs, and plasma, and use that plasma itself. You don't really have to look for a buffet cord to have a larger number of platelets, because what you are getting is some low number of platelets but enough growth factors. But you are also getting the all fibronectin and all these fibrinogen, all scaffolding proteins, and most important is A2M, alpha-2 macroglobulin, which is a broad spectrum protease inhibitor you inject anywhere, all the joints, disc, and it's very effective. So I think
Yes,
PRP would be,
yes.
Yes, PRP would be the way to go.
Thank you very much, Professor. Thank you.
Sure.
Thank you. Thank you, doctor. All the way from Nepal. This is my friend, Dr. Niraj from India. Hi, Dr. Niraj.
Hi, friend. How are you? Hello, sir. How are you, sir?
Good. How are you, sir?
Good to see you, Dr. Niraj.
Pleasure. Very good attendance. My compliments of Yosi. It's almost 500 plus people just on one go.
Yeah, thank you so much. Yeah.
Very good. And the topic and the speaker, look at the speaker and the topic. Good. So just one or two small points, just want to share. One is you said about the stem cell bone marrow. Can any adipose can be used vis-a-vis anything to do with the only bone marrow, or can be adipose derived also? By any chance?
So adipose derived mesenchymal stem cells are pretty good. However, in America, it's restricted because you have to do a digestion of the adipose tissue to get stromal vascular fraction, which has the mesenchymal cells. So you can only use adipose tissue cells in America if your patient is part of the study, IRB approved study. So, and it has a lot of limitations, and also I don't know whether it's really comparatively published, but anecdotally, my friend said that the adipose tissue has slightly more chances of infection than mesenchymal cell stem cells. So
Okay.
I had used in the beginning, but until when the regulations came out from FDA that we cannot use it, I have stopped using the adipose cells for last 4 years.
Yeah, now they're asking for FDA approval because you're doing a tissue change, you know. So that's the
Right,
restriction.
right.
That's the restriction. Another thing is, you know, how, this is about the virgin disc, which is kind of annular tear and degenerate disc. How about the operative? Can we combine with any operative procedure? If we combine in the operative thing for a post-operative repair of the annulus, is it of any use and help like we talked the other day?
That is actually the key. That should be the practice. I think we need to, I mean, in India, you are some of the leaders into endoscopic discectomy. And I think you are in a very correct position like that. If you can really identify where the, you know, after you take out the fragmented piece, and if you look for the tear, I would directly inject PRP right there, or even autologous stem cell, where you are combining both. Not just you are getting the symptomatic relief, but you are also changing up, you know, the root cause, and you are improving the you know, healing the defect. So that should be here. What we do is, you know, depending on surgeons and depending on the patient, after the removal of the fragment and improving the symptomatic presentation, we do the intradiscal stem cells afterward, not at the same time. But ideally, if you are, especially somebody like you who does endoscopic discectomy, do right there. It will be very effective.
Right, sir.
Very effective and very scientific. Yes.
Yeah, thank you, sir. So, by the way, just another
Thank you.
add-on point, you know, what you said for research point of view, good. Yeah, the platelet or the plasma cell or cells into the disc, you know. But for a
Yep.
comprehensive relief to the one part of the patient, you know, I personally like to combine, you know, when you do annular denervation along with the stem cell inside intradiscal and along with the RF. And my the one question which I'm trying to bring up is, can we do the root blocks or root steroids when you're coming out of the disc? Is it really feasible? Should we do it or not?
Actually, you should not, because see, the platelets and all are, you should not use any anti-inflammatory medication, including NSAIDs. And your
Okay.
steroid is anti-inflammatory. So I actually don't do steroid injection 2 to 3 weeks before and 2 to 3 weeks after the bone marrow or PRP.
Like any other PRP, right, sir? Right.
Yeah. So
Like,
try not to have any anti-inflammatory around when you inject PRP or stem cells.
okay, right, sir. Thank you. Thank you. Thank you for your words.
Thank you,
Thank
Dr.
you.
Mehraj.
Pleasure. Nice
Nice to
talking.
see you.
Pleasure.
Okay. We have other question from Dr. Anwar Ulhaq. After how long symptom will improve, Professor, after PRP injection for this? How long the patient will improve?
So it definitely depends on the stage of the degeneration. If there is an advanced stage, there would be a symptomatic relief. I don't know there is any kind of morphological changes that will be increasing the height of the disc. For a couple of weeks, you do not really see any effect, just like, you know, any other case. So for 2 to 3 weeks, you don't see any results, and then there would be a continuous progressive symptomatic improvement. And then, as I said, for the spine, I have not repeated less than 6 months. I give enough time for the patient to come back. So it's anywhere between 3 to 6 months, you will have a symptomatic relief and improvement.
Okay, thank you. We have one more question. This is my mentor in Indonesia, Dr. Priambodo. Dr. Pri. Hello, Dr. Pri.
Okay, can you hear me?
Hello. Yes, Dr. Pri.
Hi, Dr. Priambodo, how are you?
I'm
You
fine,
can
thank
show
you.
your video, Dr. Pri.
Oh, I'm okay. I'm using a t-shirt really. Sorry.
It's okay.
Okay. I have question about how long you have to wait from the first injection of stem cell into the second one? And how many times do we need until the patient get improved? How many injections?
So my practice is once I inject the stem cells, I don't repeat it. There is no need to repeat it because stem cells actually provides everything what you need. If you are injecting the PRP, then I repeat it 6 months to 1 year.
How about the dose of the cells? Is it the same with the other injection of stem cells? About 1 million per kilograms?
So for the stem cells, it is based on the CFU, the colony forming units, and that should be ideally around 2,500. Now, CFUs are based on the assay of progenitors, and that is based on the viability and the ability to proliferate and replicate. So if you have 2,500 CFU, that's a good number for to inject.
Okay, thank you for your answer.
Thank you,
Thank you, Yosi.
Yeah, thank you, Dr. Pri. Okay, we have so many questions, but we have a little time. So
Okay.
I think it's all done for this session. Personally, thank you very much for your presentation and also for the discussion today. I have many feedback here from the participant that really amazed with your presentation, and some say that it's so advanced. But it is very good for us here, especially for pain doctor here in Indonesia. It will make more level, gain more level for them and also for me. And once again, thank you so much, Professor. And after this edition, we have many other speakers. In next week, we have Dr. Connect, I think, for hip ultrasound. He will be presented about hip ultrasound. He is from Turkey. And after that, we have another speaker from Brazil. And also our special guest speaker, I hope that Dr. Andrea Trescott will join us on August, I think. And so for all the participants, thank you so much for your attending this webinar. I hope that you all can join us again here for with other speakers from other countries with other topic. Thank you so much. Thank you again, Professor Sudhir.
Thank you,
Thank you so much.
Yosi. I just wanted to tell all our friends that if they have any question regarding the PRP stem cells or only injection into the disc, please reach out to me. You can send me, you can share my email with them and send me any questions, and I will be very happy to return the answer to your questions. So again, it was really an honor to see all wonderful people on virtually, and I'm very interested. Even now, you have almost 450 participants are still there. In spite of it took more, in spite of it took more time than given to me. So sorry for that. Again, thank you so much for inviting me.
Yes, thank you, Professor. I hope I will see you again in Indonesia.
Yes, absolutely. Indonesia is a beautiful country, and it is on my bucket list, and I want to visit one day when this COVID pandemic is over.
Okay. Thank you, Professor.
Thank you, sir, and thank you, Linda.
Okay, so the time is, I give you back the time for Fajri.
Yes, thank you.
Thank you.
Once again,
Bye,
thank you for the excellent sharing and tips from Sudhir, and
Thank
inspiring
you, Dr. Farizi.
presentation for everyone. Before we leave, we would like to encourage all of the participants to participate in our polling or feedback of today's session. Right now in the screen in front of you, there is a polling for you to fill in right now. Thank you for those who have submitted the polls. And don't forget, for next series of interventional pain update, we will have digital dialogue with Tolga Ergonek from Turkey. And don't forget to register and join our next series. And stay tuned for any update in Dr. Yosi Instagram and Pain Institute of Indonesia YouTube. Once again, thank you very much to all of participants for joining in, and thank you for our speaker, Prof. Sudhir, and moderator, Dr. Yosi. And also thank you to our crew organizing team behind the scene. And today's event is brought to you by Pain Institute of Indonesia and supporting organizer by iScholar Academy, a B. Brown company. Stay tuned for next episode, and we'll see you, and goodbye.